Hello, I'm Lowell Feldman, licensed nursing home administrator, founder of the Lowell Group, and director of elder care services for the Castleton Group. Having had 4 decades of experience as a long-term care provider, I'm aware of the challenges that must be overcome to provide high-quality care to a growing population with regulatory and financial constraints. I have always believed that analyzing needs and developing solutions is the key to continued success. Today, technology is essential in healthcare. With the advances in diagnostic capabilities and the rapid growth of telemedicine, providers must negotiate the labyrinth of implementing new programs, educating their staff, and marketing their capabilities and achievements. As you're about to see, our partners and collaborators, all specialists in their fields, have the ability to enhance connectivity, diagnose conditions remotely, and initiate treatments to avoid rehospitalizations, shorten lengths of stay, and improve outcomes. We certainly can design and implement a customized solution for your organization or practice to succeed in attaining your goals. Enjoy the presentation and begin your journey to the future with our support and history of success.
In 2008, the National Centers for Telehealth and Technology, one of the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury, was established to meet the needs of our beneficiary population. Our focus is on the Department of Defense beneficiaries. That's roughly 9.7 million individuals, active duty, family members, retirees. Our challenge is to reach to them where they are, when they need care, and provide them what they really need and want. In the short time that T2 has been in existence, we've seen the rapid development of the opportunities to leverage mobile solutions to really reach our patient population.
Mobile health is allowing patients to get to content they need anywhere, anytime, and on any device. Mobile health will fundamentally alter the transaction between patients and providers. Patients can take an assessment on a smartphone and send the results of that assessment to their provider. This gets the patient integrated into their treatment. Providers will get accurate, real-time data rather than anecdotal data. Mobile health works with our population because the military community is tech-savvy. In fact, since we began developing apps, launching them over 3 years ago, we have seen over 500,000 downloads of our applications. T2 is reaching out on a global scale to put mobile health into day-to-day care. We are creating a foundation that will allow individuals to connect to a larger system.
The leadership of the Department of Defense identified the value of leveraging technologies as solutions to meet the needs of our beneficiary population. And it was through those opportunities that we moved forward rapidly to address those needs, looking at solutions that we could bring to the individual that they were comfortable with from their daily lives, and leveraging those technologies to help address their health needs.
In developing a telehealth strategy for the Department of Defense, T2 sees 4 areas of major concern. First, connectivity. DoD has a global healthcare system, and so job number 1 for us is to ensure that we can connect resources from wherever they are to wherever they're needed, no matter how remote, no matter how distant the person who needs that service. Secondly, collaboration. Instead of having the patient go to the specialist, have the specialist actually come in to the primary care setting via virtual technology, provide care to the patient, and coordinate in real time with the other members of the patient's healthcare team. We need to make sure that care resources, that health information is available continuously. Now we have beneficiaries who have these digital devices that they carry on their person. And so we can bring healthcare information, we can bring healthcare resources, we can bring communication with the healthcare team to the personal level. Finally, we need to address the issue of competence. In order for telehealth to be a truly effective component of the DoD's healthcare system, we need to have a workforce that is comfortable with and competent in the use of telehealth technologies.
When I started in psychology, we didn't even dream of the kinds of tools that technology makes possible today. But it's here today, and I'm convinced, I'm certain, that it's going to make a real difference in terms of therapeutic outcomes. The challenge is to get used to using those tools and to integrate them into your clinical practice. If you are already thinking about that, starting to do that, or if you're all the way there, you are now delivering to your clients, to your patients, the quality of care that is going to become the standard of care out into the future.
As we're looking forward to solutions, we're looking at how we can deliver personalized, customized care through an electronic means.
We're doing a number of things in the virtual world environment. In the virtual world, you have the opportunity for individuals to go in as avatars and interact with other people. And so a care provider can meet privately in a virtual consultation room with the patient and provide information or health care. One of the opportunities in avatar-to-avatar healthcare is the opportunity of some measure of confidentiality or privacy. An individual may be willing to go in through their computer and interact with a healthcare provider around topics that they may feel too ashamed or too uncomfortable with to talk to somebody face to face. Another opportunity afforded by the virtual world is an artificially intelligent interactive virtual agent or a virtual coach that can work with an individual to provide information about, planning for, and encouragement in making the kinds of healthcare choices or behavior changes that they may want to make. Technology is evolving rapidly, and it's important that we keep pace with that technology evolution in order to provide relevant kinds of solutions for our users. Individuals who are looking for information about healthcare don't want to browse an old-fashioned website. They want an interactive opportunity where they learn as they interact, and they want it to be relevant to them.
As we look at the technologies that we've been able to deliver and those technologies that we know are available, we can see the opportunity for dramatic changes in our healthcare system. And it's those changes that we're really looking to move forward with, redesigning the rules and regulations that currently hold us back to enable a healthcare system customized to meet the needs of our patients.
Mrs. Savvy,
Yes.
how are you?
Fine.
Are you still coughing pretty hard?
Yes.
Okay, well we do have some results. So we just got the results back. Basically, the x-rays show that you have a pneumonia on your right lung. So we do have a pneumonia that we're dealing with. Your blood work also came back and it showed that your white blood cell count is a little elevated at 12. So there definitely is an infection. What I'd like to find out first is are your vital signs from the nurse. Melinda, do you have the vital signs from this morning?
I do, Dr. Singh. Her temp's 99, blood pressure 105/60, respiration's 15, pulse is 88, and her O2 sat's been running 90 to 91%.
Okay, I think she could benefit from some nasal cannula O2.
Okay.
What we need to do in order to treat this mistake, you need to be on IV antibiotics for at least several days. And you will also need a nebulizer, which we need to do several times a day. Now, we usually do this in the hospital, so we can certainly admit you to the hospital if you like. We do have another option, however. If you prefer, we can treat you at the facility here using our acute care pneumonia pathway. But what that involves is we will start the IV antibiotics at the nursing home. We will also give you the nebulizer treatments. And Melinda or one of the other nurses will be checking your vital signs at least twice a day while you're there. But what I will do is I will talk to you in this manner at least once or twice a day to make sure you're making progress. That way we can keep very close tabs on you. If things get worse for any reason, we can always send you to the hospital at that point. But at least for now, we can keep very close tabs and make it a lot simpler and easier for you. And in fact, if your daughter Deb is around, I can even speak to her whenever she has any issues or concerns.
Yeah, Dr. Singh, I am right here.
Oh, Deb, you want to move right into the view of the camera, please?
I would prefer for her to stay here to be treated. She does get a little confused when she gets out of her environment. So if that's possible, that would be great. Mom, do
Yeah, I
you
think we have a
agree?
handle. I
Yes.
think we have a handle on the situation. Her vital signs are really, they're not too bad. As long as we're on top of it, and pay very close attention, I think we can get her through this illness. It'll be
Okay.
a lot easier for her, certainly.
Great.
So if that's okay, why don't we go ahead and start the IV Levaquin,
Okay.
okay?
I think this is great that you're able to treat her like this.
We're really excited. I'm sure she'll do really well. We have we're at a great facility. We have great nurses. They can administer all the medications. We will also be checking her on a daily basis. And we can get a chest x-ray every one or every other day. Okay?
Good.
Any other concerns or questions? Why don't we listen to your lungs first, okay, Miss Savvy?
Very good.
And then if you can get the digital stethoscope,
Sure.
you can take a listen.
Yeah. Just that.
Okay, take a nice deep breath. Yeah, I hear that wheezing. You have a few crackles in that right lung. Okay. Okay. All right.
Okay?
Okay, that sounds
Okay.
good. I got a good signal. Thank you. Okay. Okay, there are some crackles and wheezes. Your heart rate is regular. Okay, so we'll see you shortly. Probably later on today, and certainly tomorrow morning, okay?
Thank you, Doctor.
Thank you, Doctor.
If you have any questions or concerns, tell the nurse and we'll get a hold of you, okay?
Thank you.
Thank
Bye-bye.
you.
Thank you, Dr. Singh.
Morning, Miss Brooks. This is Susie from SafeWatch. We're just another pair of eyes for the nurses and the doctors down there. You glad to be out of that bed?
From this floor at Mercy Hospital in Creve Coeur, Missouri, physicians and nurses monitor intensive care patients from all across the Midwest. This telemedicine program is called SafeWatch, and it's part of Mercy's EICU. Using today's technology, these caregivers are a second line of defense.
It really is remarkable what one can do with the technology when it is put in place, when the infrastructure is put in place. As an example, in the ICU, which is probably the highest intensity of monitoring that one normally sees, if a nurse walks out of the room, it is possible for the respirator to fall off. It is possible for the IVs to stop, and that certain warnings don't trigger for seconds to minutes. Whereas on the other hand, if you're being monitored through the EICU, it is almost instantaneous when that safety measure is noted and corrected. The technology is so remarkable that you can take the camera and focus down to the pupils of the patient, down to their pupillar dilatation as to whether or not there's any changes in the patient's condition.
Mercy SafeWatch started in 2006. Its success has led to a proliferation of telemedicine programs. Today, more than 70 are in motion.
This is Susie from SafeWatch.
I want to go over the results for your last ultrasound and talk about your...
Here, maternal fetal medicine specialist Dr. Jim Bartlesmeyer connects with a pregnant patient worried about a recent decrease in fetal movement.
Of the last ultrasound you had, and everything's looking great. The baby is growing normally. If you have a nurse on the other end, she can do part of the physical exam if need be. Obviously, sonographers are doing the ultrasound. Nurses may also be doing other fetal monitoring. And so we're able to pretty much provide every degree of care that I would have been doing a consult here in the office if the patient were sitting next to me. These patients are in communities where there's not subspecialty care available, such as us. So they would have to travel and take off work for a full day. Plus, a lot of times they have to do follow-up testing, fetal testing, on once or twice a week. So it's a great convenience to them. Plus, they have ready access to us.
Mercy's a relatively good-sized organization situated through the Midwest. We have 35 hospitals, a couple thousand fully integrated physicians, 700 advanced providers, 300-plus clinic sites. And we've been on a 10-year, roughly, intentional transformation to, as we say, get healthcare right, to build a new model. And it's not hard to understand if you think, I want to have people think about it incrementally as well as disruptive. On the incremental side, SafeWatch, which is our EICU program, or any number of continuous 24-hour-a-day monitoring programs, we can fill gaps. We can be at the bedside when somebody else is not. And the interesting of what we found, even when we had 24-hour intensivists putting the EICU in place, the SafeWatch program, what we saw is a consistent trend that keeps improving to where our Apache adjusted, our risk-adjusted mortality is 30+% less than predicted. Our length of stays are much less than predicted. In that environment, by filling the gaps, reacting faster, we can give better outcomes to people. And we've taken the same consistency and done that across a number of areas. We've done it in sepsis, and we've moved from monitoring the first sepsis beds to, we're just approaching 3,000 beds across our system that are monitored real time, 24 hours a day. Now, it's just not about telemedicine, it's about what goes with it. If you just look and monitor somebody, nothing changes. Monitor with a complete rework of the workflow makes a huge difference. So part of our intentional journey is, how can we complete the care continuums inside of a hospital, make them work 24/7? How can we extend what our doctors, what our clinical teams do, and bring it to people where they are? Can we have patients who live in rural Arkansas get the same level of access to care as people who live in Springfield or St. Louis? And the answer is, in the journey, yes, we can get there. We can bring care to people when and where they need it. So if you think about the transformation that technology can enable, I have a tendency to think of a hospital as a place to bring providers and patients together with all the technology and resources so that we can build a care plan. And with that care plan, we can put an expert interdisciplinary team around that care plan. And with that, we can take a patient, for instance, with heart failure, #1 cause of hospitalization, who's coming in on the brinks of death perhaps, and 4 or 5 days later, we're sending them out relatively in good shape compared to where they started. We do that through pretty simple things: a team, a plan, monitoring against it, and making sure the right person is getting that person at the right time. I think in 5 to 10 years, we're going to look back and we're going to realize what some people have thought, which is that a lot of chronic disease, which is increasingly taking a majority of our hospital beds, that those should become ambulatory conditions. Because what do we do in the hospital? We put a plan together. We hook up to the patient, we monitor against that plan. When something triggers, the right person comes to the patient. I used to oversee an emergency room in a university setting, and we developed a neat program where we integrated our emergency room with our clinic, trying to create a continuum. And we did some pretty cool stuff. But what I realized kind of after the fact is, a lot of times the person showing up in the emergency room who was going to get admitted for heart failure is somebody I should have seen 2 days ago. But I had no clue that I needed to see them. I didn't have the technology to do it. But with telemedicine, that technology exists. And so it's going to get better, it's going to get cheaper, it's going to get easier to use, but progressively it's a journey to move from a bimodal health system. And when I say bimodal health system, most of us are trained inside of a hospital, and it's incredible the care you can get inside of a hospital. But when you leave that hospital, you go from integrated, complete care to kind of reactive, fragmented care. So if you think about telemedicine a little different, about virtual care, it's the ability for us to extend our care teams from the institution to the patient, to take our patient-centric approach that we've learned how to do and get the highest value inside of a hospital. And why can't we make that patient centricity work 24/7, 365, with us proactively bringing care to a patient instead of waiting for the patient to come to us? It's not easy. It's a challenging solution to put it all together. If we could, for instance, make heart failure an ambulatory condition today, why isn't it being done?
The challenge is that access to Parkinson's disease specialists is limited by geography. So this is a map of Maryland County, and there's Maryland State, and there's 23 counties in Maryland. And if you happen to live in Baltimore City or Baltimore County in yellow, there's many Parkinson's disease specialists. But if you live in any of these 20 of these other counties, there are none. In upstate New York, where Dr. Bigland practices, this is about a 150 to 200 mile diameter oval, and in there's not a single Parkinson's disease specialist, but there's 30 nursing homes, many of whom have individuals with Parkinson's disease. So the question is how can you reach out to these individuals to provide care? How have you been doing?
Oh, a little better than I thought I would be.
Good. What's better?
Mindset, physical. You know, I'm up to 60 minutes a week on exercise, so that's good.
60 minutes a week?
I told you, I'm not much on exercise. I'm doing the best I can. Getting better.
Good. And then with your right hand, can you open and close your right hand? Just your thumb and index finger on your right hand? So he's in Mexico City. I'm in Baltimore. Yeah, I'd like to see it.
I don't know why.
And he's an American living in Mexico. Keep going. And then open and close. All the way open. So you can see some slowness in his. And twist. And the left hand. Good. Can you stand up? Can you put your arms like this and stand up? Ideally, you'd like to have a little more space behind him that you can walk and assess his walking, but you still get a sense, you also get additional sense of his social history.
It scares me that I feel better than I did before.
Why does it scare you?
Because that's not supposed to happen. You're supposed, as I understand the way this works, is that you get worse and worse and worse.
Well, the disease progresses over time, but we try to make you function at the highest level as possible.
Well, I'm doing better than I did before.
So we're able to, extend the care that he was receiving from me in Baltimore when he came for an initial evaluation, and to continue to provide his care wherever he is.
Everyone should have access to palliative care, and telemedicine is a tool that makes this possible. Through epalliativecare.com, by using your computer or your smartphone or your tablet, you can access a palliative medicine specialist who cares and who is going to take the time to listen to your goals and your wishes and your concerns. And this can happen wherever it's convenient for you, including from your own home.
But I just don't see how we continue to provide better care at lower cost without using technology to get us there.
Very interesting. And so are there other ways, too, that you see that the demands of the baby boomer generation are going to reshape healthcare?
Absolutely. I think the challenge of caregiving from a distance is something that sort of came up indirectly. My mother lives in St. Louis. She's actually right now in a skilled nursing facility in Kansas City. If she's watching, hi, Mom. She might be. She's very interested in understanding what's happening with me and my family, and I'm very interested in understanding what's happening with her. But the technology of 10 years ago would have enabled us to understand more about what my mom's activities are and are not, and is she falling. All the rest of that's been around for a long time. But there's still no simple way for me to go into a place and say, okay, connect me with my mom in St. Louis.
Call us, text us, email us, connect with us.